also, the third talk was to be by Dr. Bhojwani, but he just called his colleagues called that he is still busy doing a procedure, and it's a pouch, so he can't kind of scrub out and leave it to somebody else. So what Sadiq and TD, I will request that we can convert his topic. What should a general surgeon do? Of course, some of it has been covered, but what exactly the surgeon should do if the injury is recognized during cholecystectomy, and before that, if the other experts would like to make any comment, and then we can maybe take up that topic. Sadak, you want?
Yeah, I just wanted to add one thing that...
No, since let Ajay respond first. He wants to speak.
Sorry, because so just I wanted to emphasize on the fact that in India, the worry is different. There's a different ground of worry. Most of these centers are at a rural area or a semi-urban areas. Worry is that the court case will be settled or will decide after 15 years. But the threatening of the family is immediately outside. That is the worry. So that's what the deciding factor in India is. So I think that we have to teach them how to tackle that and how they can help themselves from that. Yeah, please, now Dr. Sadam.
I think the solution to that, Ajay, is what we have been thinking. I will mention it, but we haven't started it. A kind of a helpline, biliary helpline, a video consultation, where the surgeon can talk to us, giving showing us the live video of what is happening during the cholecystectomy, and then we advising him what to do, what not to do. We are still not sure what will be the medical legal implications of this, how much will be our legal responsibility. So that is one. Second, as you said, that if possible, in the same hospital, in the same city, or even a nearby city, if somebody can come in a reasonable period of time intraoperatively and then advise what is to be done. And last, of course, is a referral. Yes, Sadaf,
that is one of the best supports, that somebody can come and do the surgery in their setup. Because I remember going to far away places where the patient was extubated and we have retaken up for surgery after a few hours because the patient could not be kept at that center under anesthesia, and then did a hepatic cholecystectomy and then came out. The family was at least convinced that they are not getting bothered. And the biggest worry for that surgeon was that he was operating upon a patient who was the inspector of his thana nearby, and he got injured. So you can understand how much worry is in his mind. So the only way we can help, I personally feel we can help, is we have all the instrumentation, go to that place and help. I know that the facilities will be less. I agree to it.
Yeah, I wanted to make a few comments that I think Dr. Abhinav did not touch the aspect of investigating the injury, because we are taking it into pieces in different section. And he is very generous in reaching out to far off areas also. But going and reintubating a patient, I just wanted to talk to him before also, because he mentioned at many instances where we left the opportunity from going from Srinagar to say Sopur or a far off district when it's not within your city, is practically not possible, especially in context to the patient waiting and the time duration of your travel and all is to be considered. That's a very important point. So in those scenarios, I personally have a view that if the cholecystectomy cannot be done within the area, then it's very difficult, practically not possible. So there are so many practicalities to things. And gallbladder surgery, as he has rightly put up, should be taken up as a very serious kind of surgery amongst... Of course, you take all surgeries very seriously. But if you have good communication skills for the smallest procedure to the largest procedure, on first encounter, the patient's family should have confidence in you. So that those all anxiety factors you discussed should not put you down in, spoiling the patient further. This is what is very important. From the day one, when you're planning a cholecystectomy, you just need 5 to 10 minutes to have a good rapport and communication with the patient with all those points which you had put forward. And this should be practiced by all general surgeons or those who are laparoscopic cholecystectomy surgeons. That's all. And it has been a very good presentation. All three of them had been, perfect to the topic allotted to them.
TD, maybe I can start with you. Rajesh, sorry, you want to say something?
No, I just want to say that to the Ajay's comment about going to the center. If the center is very small, and if you are going with only you are going, we might take some needle holder and suture material. But what about the other paraphernalia which is required for a good hepaticogestomy in a undilated system? I think it's a very, very difficult in our country. If you are talking about outreach program published by Birmingham Group, their district hospitals are very equipped. So I would be very much worried for that. Second important point is what you said that 95% we also get lots of referral of bile duct injury, and about 5 to 10% of our people have done they have been done a hepaticojejunostomy as such, not other form of management of bile duct injury. So hepaticojejunostomy taking at the same center in our referral is very less. What point is very important, what you emphasize for everybody, maybe sir was talking about the Bhojwani stock, we can take it in that context, that it's very important when a surgeon calls to the have a repo, like in Punjab, lots of surgeons have our numbers, and when they are referring a patient, they talk to us. That gives a patient also confidence that the surgeon has talked to the person concerned, and the moment a person lands up in PGI in emergency, our resident knows that we take our resident, that patient is coming, this is the name, and if patient comes, you go and take care, don't discuss anything and do whatever this thing. So patient is coming and he gets respect in PGI in emergency where nobody is so much crowd is there. Suddenly patient gets respect, and the problem of litigation as well as management also is better, and the litigation problem also goes lesser. Third important very point is whatever logistic you talked about the availability. These are our responsibility. If you don't have all these facility, I think we should not be repairing, as sir said. Only surgeon as such. Suppose I go and tomorrow in a small hospital in Allahabad. So should I be doing hepaticojejunostomy? It's more important to have a multidisciplinary approach. Then only this biliary enteric anastomosis should be attempted. Sometimes it is so difficult that we pray Almighty that why we are only here. Why not somebody else should have been at my place, not the me. So these are, I think, very, very important issues. And as you said, surgeon trained, magnification, and having good suture material and instrumentation, good this thing retractor system, maybe not one company, there are multiple table fixed retractors, all these things are there, then only we should start adapting. As in this scenario where we are talking about intraoperative, where bile duct is totally undilated, so it may be 4 to 5 millimeter, so we have to go up, and then we have to go to the base of the ligament, and there the dilatation is much lesser. So these are the important points. Then we can then we have, these are the important points I wanted to discuss apart from what
So
I
let's also invite Vishal is there if he wants to make some. Biju is there.
Vishal wants to say something. Vishal, please come in.
Sir, good evening to all. First,
Vishal, just a minute. Ajay wants to respond.
TD sir has raised. I think I'm fortunate that Abhinav is here. We were in the same hospital at that point in time when we got a first referral, a second referral within a gap of 10 days. And then we decided that we'll make a kit which we'll take out immediately. So we used to take the entire staff with us in the same car, the instrumentation in car, because it is, and even the sutures, because we knew that there will be nothing. So it's and the surgeon is under a lot of pressure. The family is standing outside, and we are just trying to help it. Yes, I agree. Sometimes it may be more catastrophic. It may not always be a help. But getting the patient from there to our center, once you realize it can't be done over there, is better and brings confidence to the family as well. So I think yes, we need to have all instrumentation, everything in place. Dr. Vishal, please.
Vishal wants to say something.
No, I think for the primary repair, sir, even if we are called to the center by the primary surgeon, we cannot always commit that once we attend the patient, definitive repair will be done at the same time. I think personally, I would defer the case if I feel that this is a complex injury. There may be underlying some vascular injury, because at that center we don't know facility in terms of like CM availability is there or not. So, if it is a simple, straightforward injury, then we can actually think of doing the primary repair as an expert surgeon. But in case of complex injury, it is better to assess and then put a drain, close it. We can counsel the attendant that this is a problem that we have to assess at our center with CT scan, MRI, and then we have to decide whether we should go for the early repair or the delayed repair. Second point, sir, that Dr. Biju said, the primary surgeon should defer and refer. The general dictum is that you refer early and repair late. So referring early is the responsibility of the primary surgeon. So they have to think that once they have decided to refer the patient to a particular center, they should not wait. They should refer as early as possible. And uh, third point, I think there is a concern with the primary surgeon and the attendants is the psychology that if they do the repair by themselves, that would be the one-time treatment for a complication of the cholecystectomy, because there is a concern of morbidity that lies when patient is referred to some other center. There are uncertainty when this patient will be attended, how long that it will take for the final repair to be done by the expert surgeon. There may be concern of morbidity related to the bile leak, especially the biliary fistula, when we actually plan for the delayed repair. So sometimes that happens, that injury happens, and the primary surgeons thinks that if he repairs at the same time, that kind of morbidity will not be there, and it will be just one time treatment of the complication that has happened. So that is just the psychology that goes around in the mind of the surgeon as well as the patient, because once we explain to the patient that this complication has happened, the another point comes with the attendants, that can it be repaired at the same time, because they also want to avoid the all the problems with the referral waiting period for 4 weeks, 6 weeks, or maybe longer. So there are certain issues in the mind of patient, in the mind of primary surgeons. So the other points I just want to make.
Yeah, there is a question.
I totally agree with what you are saying, what Sadaf was saying, and the point what TD was saying, that just being able to reach a place doesn't mean that you're going to repair that injury. And if you can, the whole team can go there, I'm sure it is equally easy to shift the patient to this. So it's only a question of communication between the primary surgeon and the team, patients and the relatives. If you are able to convince them, you're able to put across the point that why it is favorable for them to be shifted there, I think it would be much better decision making. Because if you go to some place, you are also under pressure that you have to perform and do the repair. Because having reached there, if you say, oh, I can't repair, then, it's the same kind of pressure which the primary surgeon is facing. The second point is, we often say that unfamiliar places, if we want to do a complicated surgery, it's not the best place to do it. And here it is, as we have been talking, it may be a high injury, it may be a small duct, you need all proper light and things like that. And then you reach there and it's not there, it's not worth it. So if you want to repair it, I think you should convince them to, in our setup, as TD mentioned, that in Western setup, they may still have much better facilities, but in our setup, better to get at our center if you are contemplating a primary repair in this scenarios.
There is a question from Dr. Karthik. I will take it. Karthik wants to know, is routine upper GI endoscopy to be done pre-operatively before all lab chole, even for simple symptomatic gallstone disease? I think Karthik is referring to the problem of portal hypertension, which can create a problem and make a cholecystectomy difficult. But obviously, it is not recommended in all patients who are going for cholecystectomy. It is only when you have a suspicion of chronic liver disease based on history, based on imaging, based on liver function tests, based on your clinical examination, that yes, you may like to do. But otherwise, no, it is not. Abhinav has asked a very interesting question. I will read it out because the audience delegates cannot see. He says that once AI comes in and robotic cholecystectomy comes in, which is supported by AI, artificial intelligence, because it can raise an alarm if the surgeon is losing the plane or is mistaking a vessel or for a duct or whatever. Will it decrease the risk of bile duct injury in cholecystectomy? Is there any evidence? Is there any data? Biju, Sadek?
So there are programs now on software available which you can superimpose on the image that you are seeing, and it at least tells at a point that you are in the wrong place of dissection. But it's still evolving. It is not foolproof at this point of time. But these are publications in Annals of Surgery which has come, and there are commercially available softwares which you can sort of introduce in your system, and at every point of time you can superimpose that and get an assessment that whether you're in the right place of dissection. And I think there's a lot of work which is going on in that, and hopefully if it is affordable and if it is usable by everyone in peripheral centers again, it should, or at least it would sound an alarm that you are in the wrong place. So that's possible.
Sadiq, I would disagree, because unless you have a cholangiogram, how would even AI tell you whether it is cystic duct or common bile duct? You have to have a preoperative cholangiogram which can be superimposed on the operative.
No. What it does is, I mean, the way principle this works on is, it is basically large data collection. So what it does is it processes a whole lot of videos of cholecystectomies which are going on, which have gone uneventful. And then it sort of establishes a pattern that this kind of anatomy and this area of dissection is safe. It doesn't say what is the bile duct, what is the cystic duct. It says that the area of dissection is unsafe, or this place where you are dissecting is inappropriate. The surgeon will still have to choose whether in that particular situation it is there or not. So it is just large data processing. And when you process large data, you get various types of cholecystectomies, which you put in that. And then there is a lot of work, each one saying in each video that which is the correct thing and which is the abnormal place to dissect. So it comes out after a lot of pre-work in that. And that's why it is not foolproof as yet, because there is such a wide variety of anatomical variations and situations which we encounter.
So for the last topic which Dr. Bhojwani was to cover, I will pose questions to primarily Sadiq and TD, and maybe other panelists or other experts can also respond, that what should a surgeon do? So I am a general laparoscopic non-biliary surgeon. I'm doing a lap chole. I'm doing dissection in the Calot's triangle, and I see a drop of bile. Sadiq.
No, again, as we discussed, when I'm dissecting in that area and I see a little bit of bile, I am worried. So that's the first thing. So as you said, it's yellow sign, you stop. Then you assess the bile. You look at, as you mentioned, the characteristics, golden yellow, thin, watery, free-flowing bile from the central area and not from the peripheral area of the thing. And as I said, it is identifiable source of leak, unidentifiable. And identifiable, what I mean is, usually you can make out that it's the gallbladder which has been punctured in that. And you know that it's nothing to panic about. But if it is unidentifiable, central, golden yellow, wait, stop, and then get somebody to have a perspective on that. If
nobody is available, I am all alone.
Nobody is available, and if the suspicion is high, which you should be having at that point, I think I would suggest for them to stop there, put a drain, and come out at that point of time. Less harm done at that point than doing any more dissection or
no further dissection,
any more evaluation of that, and refer this patient.
Very important. So if it is in the Calot's triangle, if it is central, if it looks like CBD bile, you cannot make out what is happening, no help is available, Dr. Sadiq says, and I fully agree, don't do any further dissection, leave a drain and come out. TD, same situation, but it's a thin-built patient. There is no fat in the hepatoduodenal ligament. I can see that there is a hole in the CBD. Cystic duct is seen, gallbladder is seen, cystic artery is seen. I can see that it is a small hole, maybe caused by the tip of the hook or whatever. And I'm very sure that it is the CBD. What should I do? I am a general laparoscopic surgeon in a small nursing home.
Sorry, I think if it is, we are sure that it is common bile duct and we can see the anatomy that it is looking like bluish and whole length we can see. Then probably we can complete cholecystectomy and put a drain. Nothing to the that hole. Put a drone and then next day we can start. We pharmaco we say this pharmaco sphincterotomy, and then we can start Buscopan and see, and then we can also think about what is the drain output. Based on that we can talk to our medical gastroenterology colleague and go for medical sphincterotomy, gastroenterologist colleague, and go for endoscopic sphincterotomy if required. Otherwise, if it is very low output and if it is going down, then it will heal on its own, most probably without any problem.
What about suturing that hole?
Suturing is, sir, as we are discussing repeatedly, suturing is create more problem, and even the size of the needle can puncture. Bile is a detergent, so more you puncture, more bigger hole you make. So it's just if a small hole can be left alone, can be sphincterotomy can be done. Obviously, one drain has to be put in the subhepatic area. So
You
suturing.
mentioned about pharmacological papillotomy, Buscopan. Can you elaborate on that?
Sir,
When do you start?
By we start sometimes some difficulty is there. We start in the evening only by IV, and the next day we can go switch over to oral and go for a week. So that is we follow sometimes when we are having a patient where we feel that some clip is not very good or something like that. Then we immediately start this type of medical sphincterotomy. Though there is no much literature on that, but these are the things which can be done. Obviously, next day, how much is the bile output? That is very important in the drain. And what is the condition of the abdomen? All those things will decide further management.
Only thing I will add before I hand over to Sadiq is that in any of these situations, the same time, the same day, you have to inform your medical gastroenterologist, the endoscopist, that he or she should be ready for intervention, maybe tomorrow, maybe day after, depending on the clinical course of the patient, and because that would definitely be a help. Sadiq, you wanted to say something?
I mean, I think it is important what scenario we are looking at. And if you're talking of a general surgeon in a small place, so I think all what TD has suggested I would do, but along with that, I will refer this patient immediately, because no point keeping that patient and trying to observe how much bile is coming and all. And I am of the opinion that, again, bile is not good for the peritoneal cavity, even if it is coming out in a drain. So if you refer, you may be able to do an early ERC and put a stent so that bile leak is minimized. But in a setup where you don't have, as you said, if you have a medical gastroenterologist, yes, inform and you can take a decision. If you don't have that facility, then I think refer, even in the same city, immediately to a place where they can evaluate and take decisions based on what's happening.
TD,
Can I say one thing?
Yeah, Vishal, please.
Sir, I think it will also depend at what stage of the procedure we can see the bile. Suppose cystic artery has already been divided, and then we notice some bile in the hilar area or in the Calot's triangle. Then should we leave the gallbladder in situ?
Yeah, you asked that. Biju addressed it, and Sadiq also addressed.
Sorry, I was on the YouTube earlier.
Yeah. So what Biju felt that if you haven't separated the gallbladder from the bed to a significant extent, you will have some blood supply from there. And he was of the opinion that you need not do any further dissection, because obviously if it has happened at that stage, which means that you haven't done any dissection in the bed. That was what Biju's opinion.
But can we go ahead with a subtotal cholecystectomy? Because we are not dissecting in the Calot's triangle. Even if we see some bile in the Calot's triangle, so if we take out the part of the gallbladder like we do in the subtotal cholecystectomy, so that can avoid the risk of ischemia.
Yeah, I personally would agree with Biju that if not much part of the gallbladder has been separated from the liver, I would probably be advising the surgeon to just stop, do nothing. Because see, that means that there is something wrong. And the more you try to do dissection or anything, probably more injury is likely to occur. That is what my personal. So the second scenario, yeah, Sadiq.
No, good. Let's do this.
Second scenario, TD, we have done the Callot's triangle, cystic artery, cystic duct. We were clear, a critical view of safety demonstrated. There is no problem. Now we are dissecting in the gallbladder bed. I'm using cautery and I see a drop of bile there.
So again, sir, same thing. Is this drop of bile coming from the bed, from the liver area? Then would obviously it would be as golden as it is for the common bile duct, or it is because of the puncture of the gallbladder. So
it is not gallbladder. Gallbladder is intact. I don't see any hole in the. It is in the GB bed coming from the liver.
So and we are not seeing any tubular stricture. So there would be two scenarios. So while dissecting, are we able to see any tubular structure? Then we can think of about this bile duct, sectoral duct injury, duct of Luska, whatever we call it. And if you are not seeing any tubular structure and the duct is so small, then again I think putting a drain and going by the same thing what we discussed, that we can refer and put a drain and this thing. Otherwise, if you are able to see the tubular structure, then probably intraoperative cholangiogram might be required here.
Cholangiogram not available. I am working in a periphery nursing home.
Putting a drain and referring the patient again to the.
And what about clipping it?
Clipping, sir, as I said, tubular structure, if you are seeing, you can clip it, but that size is very important. If it is very small, less than 3 mm, then probably it is draining very small segment. But if it is more bigger and you can see a tubular structure, then probably referring would be better, because clipping, the only thing is that whether it is connecting to the main system or not. If it is not connecting to the main system, then it might have type B injury, which might not have any consequence in the future, and which might produce sepsis in terms of that segment not getting drained and then stasis and going having some sort of a small abscess formation. Otherwise, it might not have any consequence if it is very small. So putting a drain and I think sending would be much better, and then doing a cholangiogram later on in a higher center, and then deciding further planning.
So I have a slightly different take.
Yes,
can I, Dr. Kapoor? Dr. Kapoor is, so we have bypassed and we can do what we want.
Yes.
So, see, I think, TD, you are worried about aberrant duct, right? And again, that would be a little more central than peripheral in that.
Yes.
In this situation, which Dr. Kapoor was probably hinting to, is you are dissecting the GB of the liver bed, and then you encounter there's two situations: cholecystohepatic duct or duct of Lushka. Both of these, I think, if it's a cholecystohepatic duct or duct of Lushka, I think we are okay to clip or suture whatever you are comfortable with and take care of it. Of course, put a drain and then follow it up. If it is more central in that area, then there is a remote possibility of an anomaly wherein a right posterior duct opens into the gallbladder or into the cystic duct. We have seen that very rare over all these years, 1 or 2 cases like that. If that scenario is, then what Dr. TD was mentioning are the considerations that if it is very small, you may still clip it. Clipping a small duct is much easier because it doesn't result in continuing bile leak, and if it is a small segment, it will atrophy. But just by the size, we cannot say what area it is draining. Mm-hmm. So in such situations, my philosophy is exactly like what TD described, that if I suspect that it's an aberrant duct which has been injured, then we would put a drain and assess later that what kind of injury it is, and subsequently go on for repair. And this is not the best duct to repair early also, because these are much smaller and more difficult to repair. So I think we are coming to 9 o'clock. I'll say that if Dr. Shahidor is there, if he wants to make any comment he's welcome to. Dr. Pratik is there if they want to make any comment before we close the session. Dr. Kapoor is particular about closing on time. Dr. Shahidar?
Yes, sir.
Would you like to
can you
make
listen
any
me?
comment? Yes.
My one questions to the all learned speakers. Is there any way to assess preoperatively that these patients have biliary anomalies or have biliary problems like inflammatory adhesions around the calostangles? Is there any way to understand? Is there any way to assess before operation of the cases
Biju, is
so
he
that we
there?
can avoid malignancy?
Biju, are you there?
So, yeah, yes, sir, yes, sir.
Please answer.
So, we cannot, point number one, we cannot improve the safety of cholecystectomy by pre-identifying the anomalies and by teaching somebody about the anomalies in an extensive way. The reason is anomalies are there either in the arterial or ductal side, at least in 50%. Okay. So let us say in arterial side, 500 cases we have evaluated the CT. The classical anatomy, we have seen so-called classical anatomy only in 27%. So what are we trying to teach as the anomaly? So this is a difficult area. So cholecystectomy should be done based upon principles and safety rather than trying to educate somebody about the HPB, bile duct or arterial anomaly. This is what my message. So apart from basic simple anomalies, complex anomalies need not be learned, and that will not improve the results of cholecystectomy or safety.
Dr. Biju, I think what he wants to know, pre-operative, can we predict? So I think in Meiji syndrome, Dr. Saidur,
Yeah,
and if
preparedness.
there is a history of endoscopic stenting and removal of common bile duct stone, or stone as such, presence of stone as such in the common bile duct, and then small contracted thick wall gallbladder on ultrasound, and then there is a palpable gallbladder lump which makes the size of the cystic duct and the length of the cystic duct very small. So these are the some pointers towards the and a history of acute severe cholecystitis and acute cholangitis also. These are the some important points which predict that this gallbladder might be difficult in terms of doing cholecystectomy.
Thank you. So Dr. Kapoor is here and he'll
We need
probably
to close
it.
because we start on time.
So,
We close on time.
may,
Don't
may,
go
may,
beyond that.
may I add another questions?
No,
Sir?
please. Tomorrow. We need to close at
Okay,
9 p.m. So,
Oh, yes. Thank you so much.
sorry, Dr. Shahidur. Tomorrow, please join and we can have a more
Okay, thank you,
discussion.
sir.
Yeah, thank you. So, I would like to thank Sadiq and TD for moderating, and Biju and Ajay. Rajesh Bhojwani could not join. He was busy, but I think Ajay and Biju and Sadiq and TD covered most of the points that Rajesh was to cover. Thanks to Abhinav for joining today, although his session is tomorrow. Thank you very much, Abhinav. Thanks to Sadaf. Thanks to Vishal, Professor Shahidur Rahman. So we will continue this masterclass tomorrow at 7. Yeah. Good night, everyone.
Yes, I'd like to join
Thank
tomorrow.
you.
Thank you. Thank you very much. We had about 60 plus delegates watching live, and the views of the uploaded videos is much more than that. So I think our effort is not going waste. People are watching these sessions, and I am sure they are liking it. Thank you.
Thank you, Dr. Kapoor.
We
Good
will
night.
close. Thank you.
Thank you, sir.